oh no, my nurses are very good, my doctors are very good, I don't have constipation. My Aunt Nellie had constipation, and she had surgery, and she almost died. And all of a sudden I'm hearing the medical history of Aunt Nellie. I want the quality time that I'm spending with my patients to deal with the 3 or 4 things that they've identified are the problems. So it really can streamline your clinical practice. So we looked at the degree of weight loss, the mean weight loss in 1 month and 6 months. It wasn't large amounts. But when we started looking at the other components, about a quarter of the people had decreased their weight in the last 2 weeks. Half of them were unchanged in the last 2 weeks. But that doesn't mean that they didn't lose a lot a month ago or 6 months ago. In terms of compared to my normal, in the past month, my food intake was less in about a third, no change in about half. What's interesting is how many of us asked our patients, has your intake changed? How many of you asked that question? Do you think you're getting a really good answer? What's interesting is when we looked at it, we found of the patients who checked unchanged, 16% of them also checked off taking very little of anything. And even the people who checked off taking less than usual, a quarter of them said they were taking very little of anything. So when we ask, has it changed, they answer what we're asking. But it may not what we really need to know. And when we looked at the data, we found that a lot of the people who were saying unchanged were over 65 years of age. Which means there's a lot of geriatric undernutrition that maybe has been the same for the last year, the last 6 months. It hasn't changed. So that's one of the reasons when we talk about the conditions on the professional component, we say age greater than 65 because that's a risk factor based on what we saw here. The type of intake we later evolved to put a slight variation on it, but it basically was that about 2/3 of them were taking very little solid food. And this is across the board. It didn't make a difference in terms of what kind of answer they had. Now the other issues in the nutrition impact symptoms, box 3, we found that the default in all cases is, do you have problems, you don't have problems. The default was no problems. Almost 60% of the people said they had no problems eating. Does that sound like your patients that you see in clinic? 60% have no problems at all. But what's interesting is we found that of the 60% who said no problems eating, they checked off multiple, sometimes 4, 5, or 6 additional nutrition impact symptoms. So when I was asking, do you have problems eating, or when you ask, are you having problems eating, they basically say, I can chew it, I can swallow it, it stays down, and it doesn't come out too fast or too slow. That's problems eating. So what we need to do is actually understand what are the things that are the impediments to eating. And so when we looked at the people who had no problems eating, clearly a number of them still had significant. There were 10% who had mouth sores, dry mouth, other aspects of pain. Things that truly, if you have one, might have an impact, but if you have 4, 5, or 6 of them, absolutely work together to be an impact. Clearly those people who checked off problems eating clearly had a lot more symptoms. But look at this. Mouth sores was the same in either one of them, and that's what we tend to think of as one of the major components. But we also had a quarter of the people who had constipation, a third of them that had nausea, a quarter of them that had dry mouth, pain. So this is something that's really giving you important information, what you can do to intervene with the people who are having the impediments. So while 60% reported no problems eating, over half of them checked off one or more of the symptoms. So in other words, we're not asking, both for the box 2 and box 3, we're not asking the questions we think we're asking, but our patients are answering the questions we're asking. This is the ECOG performance status, or the WHO performance status. And again, it's based on those same components of 0, 1, 2, 3, and 4. Again, simple surgeon. 0 is normal, 4 is bedridden, 1 is fairly normal, 2 is less than half the time in better chair, and 3 is more than a half the time in better chair. So very simple ways of remembering. I will tell you there's something that I would probably change now if I were to do it, and that is in the PG-SGA, we give both of these a score of 3 because you can be bedridden for other reasons than just things related to prognosis. You could have just had surgery and your doctor doesn't want you to get out. I would probably, if I were to do it again, I'd probably still give it a 4. But, you know, we learn over years. So the professional or clinician worksheets. Again, as I mentioned, 92% were either dietitians or nurses. There was a 90% completion rate. The components of the worksheet, and we'll talk about this a bit later. This is not part of the short form, it's part of the full form. The aspects here are those components that have to do with their disease and the relationship to their nutritional requirements. So if you've got other catabolic illnesses like HIV, presence of a fistula, poorly healing wound, those are all captured here and get point scores. This is actually has to do with fevers, how high and how long, and whether or not there's corticosteroids. Now, in terms of the fever, you only capture, you look at both how high the fever was and how long they had it, but the reality is that you only score the one that's highest. So somebody has a low-grade fever, but for a very long period of time, you may give the 3 points to the duration. So it's not additive with those two, it's whatever is the highest of those two. The corticosteroids we'll talk about in a minute. This is the physical exam, and from my perspective, that looks very scary. We did this originally 20 years ago because dietitians did not do physical exams. And we worked with what was then known as the American Dietetics Association. And they say, we agree this is really important to know how to do a physical exam from a nutritional perspective, but you need to tell us how to do it. So what we did is we ended up doing the kinds of things that you need to look for, but it looks a little more complicated than it is, and we'll talk about that. We then have components of the categorical components of A, B, and C, and then the triage based on the point score. These are what are known as the prednisone equivalents. So depending on what kind it runs prednisone, it will tell you the dose of high, low, medium, and high, or the other one's cortisone, hydrocortisone, etc. So you can know what are the effects in terms of the most common drug-induced loss of muscle is corticosteroids. So people are on it and we don't think about it. And it's interesting, a number of people, a lot of physicians will say, oh, a little bit of corticosteroid stimulates their appetite. So I'm just going to put them on low dose chronically. That's probably the worst thing you can do for a malnourished, hectic patient. If it's in hospice, that's another deal, because then you're treating quality of life only. But for somebody who you're treating and you want to have the impact on outcomes, probably it's the worst thing. I once said that there's nothing worse than a hectic, malnourished patient, except for one thing, and that's a hectic, malnourished patient on corticosteroids. You accelerate the muscle loss in that setting. Again, physical exams. Again, none of these people have been trained, so to know that there were 13% who had obvious muscle mass, I don't know if that's true or not, but again, we'll address the importance of the physical exam from that. So relax is easier than it looks is really my kind of take-home message for the physical exam. We'll talk a little bit more about that. There's 3 components: fat, muscle, and fluid status. It's subjective. So the reality is the total number of points for the physical exam is 3 points. In reality, unless you've been drinking too much port wine and you have had no sleep in the last 3 days, the chances of you getting somebody confused between severely malnourished or depleted and mildly depleted is very small. And even if you had too much port and you had no sleep, you're only going to be off by 1 point. You're going to be difference between mild and moderate and severe. You're not going to do anything worse. So relax. It's going to be okay, but it's making you look at it in a new way. Again, globally, a lot of times if somebody's overweight, you're going to be able to see the temples. You may not be able to see the triceps or the biceps. You may not be able to see some of the others. So look where you see it. And if you see evidence of weight depletion, lean tissue depletion, muscle mass loss, that is more important than all the fat information you take in. Now, if you have loss of fat and loss of muscle, yes, that makes a difference. But if I see evidence of muscle loss, muscle deficit, that's more important than if the patient looks obese. So that always takes precedence. We'll talk a little bit more about these. Fluid status, is more excess fluid, and it has to do with if you've got too much or too little in terms of what's happening in terms of what impact does that have with the weight. Now, I will say one thing that we don't address dehydration or depletion. But in terms of the sneaky physical exam, in terms of something that you can do even if you don't have an examiner, what's the best way to address a patient's hydration status? To see if they're depleted. If they're over hydrated, you look at the dependent parts of their legs, you look at their ankles, etc. Although I will tell you, if you look at your ankles and you're walking down the hallway and you see somebody that's got a very large leg on one side and not so big on the other side, and they've lost weight and they're inactive, ask the doctor about whether or not they might have a blood clot.